for about 4 years. In addition to various international assignments in Somalia, Sudan, India, Liberia, he has more than 12 years experience of working in the public health sector of Pakistan. So, and our next panelist is Dr. Abdul Ghafoor Shoro. He is the Secretary General of the Pakistan Medical Association, and he serves as a senior physician at Aga Khan University Hospital and is the commissioner of the Sindh Healthcare Commission. His global health involvement spans 2 decades. Dr. Shoro has held leadership roles in medical organizations and managed impactful healthcare projects. His educational background includes a DPHC, a Master of Administrative Sciences in Health Services Administration, a PGDPA, and MBBS degree. Dr. Shoro's extensive experience uniquely position him in drive the positive change in the healthcare, combining clinical expertise and administrative skill. Welcome, Dr. Shoro. So this is the, I gone through it very quickly because of the time constraint, because we want to bring something which is discussed with the participants as well as the panelists. We have many questions to ask. So our first, we are presenting a paper on by Dr. Sonia Umar, who is the Punjab University, who is the associate professor at Punjab University, and this is her own research on the primary health care, on MNCH, and as a part of universal health coverage. So over to you, Dr. Sonia Umar.
Assalamu alaikum ji everyone, Dr. Razia and all distinguished guests over there. So Dr. Razia, can I change my slides, or your IT team over there, they are going to change it? Alaikum ji, am I audible?
Dr. Sonia, you are audible, and they will change the slides, please.
Alrighty, thank you very much. Assalamu alaikum to everyone. Good afternoon. It is a great pleasure being a part of this panel discussion. I would have loved to come. Thank you, Dr. Razi, and other people who have accepted my abstract to present in this conference. But it's okay, I'm presenting online. I was also in a very important conference that I will share a little finding of that conference that is very relevant with your session today. I was at FC College. So today I'm going to discuss with you or present my findings on the very important role of the lady health worker. So the title of my paper is A Light in the Grim Sides, Investigating Lady Health Worker on Maternal Healthcare in Rural Pakistan. So may I have a next slide, please? So before I go into the objective, I quickly would like to tell everyone, I am sure people over there, they already know that Pakistan is facing considerable health challenges since its inception and lags behind in many international targets. So the Lady Health Worker Program is one of those significant steps that state has taken in the past decades, and it has brought lots of improvement in the primary health care. As a social scientist, जो चीज हमें बहुत ज़्यादा attract करती है, that is the connections of the lady health worker with the communities. Those communities which are not very easy to reach, those communities which are not very easy to work with, they have to face lots of difficulties when they go there. They have to face the culture constraints, the social stigmas and other things. So this program is very comprehensive. It's an extensive program, and the program of the community health worker, it actually is a worldwide program. It is breakthrough in Pakistan health service care. It has connected communities. It has enabled different segments of the population, especially the women, with the awareness and provision of the first level medical healthcare service with a great focus on the maternal health. So what I'm going to do, I'm going to focus myself on the maternal health. The study is going to investigate the effects of the lady health worker services towards the maternal health care with special focus on the awareness on the family planning program. To all the distinguished guests, I would like to to share that my PhD research is on the maternal health and maternal mortality, and Pakistan is among those. Pakistan stands fifth in terms of the high maternal mortality, and lady health worker role in creating awareness, in telling the women to adopt antenatal, postnatal care, or the other methods through which we can reduce the maternal mortality. It is very pivotal. So I have this is my main objective is how they create awareness, and I have also would like to discuss a bit about the challenges these lady health workers are facing when they work in the rural communities. Next slide, please. So quickly, this is a cross-sectional explanatory research, and it is qualitative in nature. The study has used the inductive approach. We also call it a bottom-up approach. I have worked in the southern Punjab district. I have 3 districts I have worked. These are Laiya, Dera Ghazi Khan, and Rajanpur. So the universe of the research is lady health workers. I opted for a focus group discussion as a tool of data collection, and thematic analysis was used to draw the major findings of the research. So how did I just quickly I would like to share that how did I reach to these lady health workers. I had to get permission from the Secretary Health Ali Jan, who is and I had to get the list of the lady health worker working in all these 3 districts, and I had to make a list and I had to approach them, and then I went to the field and I conducted 3 focus group discussion in the district headquarter hospital DHQ of each district. I've already told you objective of the research. I wanted to know what exactly they are doing for the maternal health care when they go to the communities. So the total number of 24 lady health workers were interviewed. There were 3 focus discussions. The average age of the respondent reported between 35 to 45 years of age. The greater majority, 16, were they were married with 3 children. Average income मैंने यहाँ पे लिख दी है, और the greater majority they were intermediate pass. हालांकि इसमें qualification intermediate या bachelor's required नहीं है, but still जो है वो metric या intermediate जो खवातीन है वो इसको apply करती हैं, and they work as a lady health workers in the communities. Next, please. So one of the very, very important component on maternal health, that is the family planning, we all know very well. And as I was in the morning, I was at the FC College and at the Pakistan Council and UNFP and PAP की collaboration से conference हो रही है. So there was lots of emphasis on family planning कि किस तरह से हम Pakistan lags behind in it. और lady health worker जो कि community में जाके they are playing a very important role. They are dealing with the people, they are dealing with the families, the mother-in-law, the husband. So lady health workers, and average on catchment area 1000 individual उनका होता है, और every 272 hours वो visit करती हैं एक week में एक field के अंदर. So जब वो बात करती हैं family planning में होता है, तो in exactly उनके अपने words ये होते हैं. The most difficult task while we engage with the rural community is their campaign on family planning with the married couples, those who are using the contraceptive. So there are so many social and cultural barriers ranging from declaring family planning methods haram to the myth कि इसको bareness जो है वो लेके आती हैं मेल और फीमेल के अंदर, फिर मेल superiority है, फिर decision on the family planning is always in the hand of the men. So वो कहती हैं कि this is their prime job, and if they do it nicely, it definitely saves the life of the women in a true sense, because they go for the family planning method. They are able to give spacing between the births, so that can help in maintaining their good maternal health, and of course it saves lives. Next, please. Very important. Doctors are there, your panelists are there. We all know how important is the antenatal and postnatal care. So according to the WHO, 8 antenatal care is very important. Those visits of the women to the health available health service जो है वहाँ पे जो, this is very important. ये खवातीन when they go to the communities, when they go to their houses, they just become a part of those communities. It is very important the way they communicate with them. So they do spread awareness on the antenatal care. They tell them the right healthcare facility, जैसे BHU hospital होता है villages के अंदर, they can go there, they can go to THQs. But of course उनकी जो हमारे पास findings थी वो यही थी कि antenatal care southern Punjab में as per the report of the multiple indicator cluster survey 2018, it is southern Punjab के जो districts हैं ये सबसे ज्यादा लो एंटीनेटल केयर वहाँ की खवातीन ले रही हैं, और मेरा रिसर्च एरिया भी वही था. तो उनके वर्ड्स में उन्होंने कहा जी, वी लुक एट द पेल डेड फेसेस ऑफ द वुमेन, दे आर गिविंग बर्थ एवरी ईयर एंड दे कंप्लेन ऑफ मेनी कॉम्प्लिकेशंस ड्यूरिंग प्रेगनेंसी. और उनकी वल्नरेबिलिटी वी कैन सी. हाउएवर वी डू आवर बेस्ट टू एस्टैब्लिश आवर लाइजन विद देयर फैमिलीज. Families' consent are very important because there are lots of issues with the people over there in the southern Punjab about the mobility of the women, about the decision making, about getting permission from the family, going to the medical health. So these sort of, और इसके अलावा spiritual healers हैं. Then there's a parda issue, the जिसको हम दाई कहते हैं, the traditional birth attendant, their role is very important for many complications that is.
Dr. Sonia, Dr. Sonia, may I interrupt, please? Please come to the conclusion, and because of the sparsity of the time. So
all right. So okay, Dr. Razia, awareness आगे. Then the next slides quickly आप कर दीजिए. So other information, it was there. Actually, it's a qualitative research. I tried. ठीक है. So other information that is given to those women by the Lady Health, it includes sanitation and nutrition, or that is very important for the a good maternal health. आगे please इसको next कर दीजिए. Also there are linkage, बस इसमें मैं जरूर emphasize करूंगी, the very important role of the lady health worker. They create a linkage of rural community with the formal available health system. Not necessarily we all the time complaining that we do not have the facilities. We do have the facilities, but we should know, the rural community need to know when is the right time to go to the which facility. Sometimes the women is bleeding at the time of pregnancy, but instead of going to the DHQ, the district headquarter hospital, the family take the woman to the BHU or the THU where the right information is not available. So that is also very important. The lady health worker, they create a linkage between the available healthcare system or the community को वो बताती हैं, and that sort of information is very important. It saves life and the people get the right amount of maternal health information available in their villages. Next please. Challenges में बस quickly Dr. Razia बता देती हूँ. Lots of challenges they are facing. One of the very important जिसमें मैं emphasis करूँगी, let's not talk about the salaries or the other equipments or the stipend or the transportation, monitoring and evaluation. They really need supplies of the equipments पर इनका मसला है. One is thing that lady health worker program was started with pure emphasis इस पे maternal and child health care के पर बहुत था. Now what they are complaining, that has been shifting to the polio and other campaigns, and this is what that was also part of discussion today's conference where we were talking, and many big guns they were talking there कि इनका जो अब शिफ्ट हो गया हुआ है, that is affecting the family planning and maternal health and child health care का जो उनका काम है उसमें वो बहुत ज़्यादा impact कर रहा है. So I think they should be strict to the work जो कि initially इनको 1994 में इनको काम दिया गया था, और I think दूसरे programs के लिए और या तो induction ज़्यादा होने चाहिए या फिर इनके ये कि working hours उस तरह से manage किए जाएं जिसमें ये maternal and child health care पे और family planning के ऊपर real focus कर सके. Next please. Next, please. So the policy recommendations for the because in whatever little I have said, it really put emphasis a lot on the very important role of the lady health workers in the rural communities. As I said, it's not easy to go to rural communities and to talk to the families and convince the families. So इनके role को बेहतर करने के लिए obviously we have to see के supply of the medicine and contraceptives होने चाहिए. Lady health workers may be equipped with the necessary and functional equipment. There's a significant need to improve interdepartmental coordination. Sometimes they told me that they make a reference, वो referral देती भी है, but that is not acknowledged, या उसको वहाँ से आगे referral system उस तरह से acknowledge नहीं करता जब वो खवातीन वहाँ पे help के लिए जाती हैं DHQ और THUs के अंदर, तो उसको improve करने की जरूरत है referral को. तो interdepartmental coordination is important, and there have been sit-ins and protests. So of course there's a lots of need that government जो है वो emphasis करे और इनकी salaries और stipends पे improve करे, and also a conducive environment. इनको harass किया किया जाता है. They are communities, the gatekeepers of the community. Sometimes the imam masjid and the other people, family planning or contraceptive पे especially ये बात करते हैं, तो they have to face lots of difficulties and harassment issues भी इन्होंने जो है वो बताए हैं. For maybe for that, maybe the health department and the law enforcement agencies, they can play a pivotal role and make sure the lady health workers proper and smooth functioning in the rural communities of the Pakistan. Thank you.
Thank you, Dr. Sahar, for your presentation. Now we move to Dr. Zafar Mirza for his keynote speech. Please, Dr. Zafar.
बिस्मिल्लाहिर्रहमानिर्रहीम. बहुत शुक्रिया डॉक्टर रज़िया सफदर. Our chief guest, General Nigar Jokhar Khan, it's a privilege to have you, madam. I have profound respect for you. And fellow panelists and ladies and gentlemen. The title of this conference, before I come to my title of this session, is very telling. And it is light at the end of the tunnel. As if there is a end, and if there is a light, a hope in times of despair. So actually, it's this title speaks about the gravity of the situation that we are all in. So within that context, I thought that I will, when I was approached for this session, I thought that we should also try to lit some light at the end of the tunnel by collectively thinking that how universal health coverage, the idea of universal health coverage in Pakistan can be realized, and how this can bring some hope to our people, suffering people. So what I'm going to do is that I'll speak through my slides. And this is just to set the scene about what universal health coverage is all about, where we stand, what are our challenges, and where to go from here. So if I can have my slides, please. Very good. So. It seems like no light at the end of the tunnel. चलें, मैं बात शुरू कर लेता हूँ. मैंने बड़ी मेहनत की थी अपनी स्लाइड्स पे. नहीं जाएगी. Should I wait, ji, or should I continue? चले, ठीक. चले, ठीक. So I'll begin by explaining for a minute why this title, Envisioning Universal Health Coverage in Pakistan, and how we can actually make it possible. So there are three key reasons why I thought that this should be the topic. First, we all talk about health as a fundamental human right. So if it is a universal human entitlement, then everybody has this, should have this possibility for a decent, essential healthcare. So that's the first and foremost reason. And we can go, a lot of detail behind this idea. We are signatory to WHO Constitution. We are members of so many international covenants. And last but not the least, we are also signatory of the Sustainable Development Agenda. And we have a specific goal there on universal health coverage. So we were supposed to actually achieve universal health coverage by 2030. So right to health provides us a very good rationale, very strong foundation to have this discussion. Secondly, it's not that our policies are oblivious to it, since we are signatory to SD agenda. Our policies actually already are aligned with this. So our National Health Vision 2016-2025, our 12th five-year development plan, 2018 to 2023, our provincial health policies, they are all talking about universal health coverage. Sometimes they don't use these words in this way, but basically they are all structured to provide healthcare to everybody. And last but not the least, I have a very major reason also to present as a basis for having this discussion, and that is our current situation with reference to the public health crisis that we have in the country. There is no other word, politer word, smoother word that I should be using. There is a public health crisis in Pakistan. And this also should be provoking us to have very serious and in-depth discussions at how we can overcome this by providing healthcare to everybody. Because the nature of healthcare is such that unless everybody is safe, nobody is safe. And we witnessed this during the COVID-19. Even the North Hemisphere was not safe unless the South Hemisphere would be vaccinated. So such is the nature of healthcare. So by going by this also, we have very important responsibility as a society, as a government, as global health to advance towards universal health coverage. Now, I have already used this terminology a few times. What do we really mean by universal health coverage? And I have noticed that even at a high policy level, sometimes people continue to have different understandings about this. So I thought that it will be very helpful that I quickly read through it, that how WHO has formulated the concept of universal health coverage and how it defines. So UHC means, and I'm reading, it's quote unquote, UHC means that all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. So UHC is not just a slogan, not a rhetoric. It's actually a full approach for covering everybody with quality health services of all 5 kinds, including those who cannot pay. So that's the, so but the basic point I want to make here is that sometimes people use health for all or universal health coverage. Acha idea ji, is pe bhi kaam hona chahiye. Actually, this is a whole science, and it's a whole policy standing on which a lot of scientific work has happened now, and we will hear about that also as we move forward in this meeting. So I have talked about third reason that why UHC must be thought about and talked about is the public health crisis that we are going through. So let me just give you a few glimpses of this. I wish that we had slide on the screen, but let me, maybe I will show you later. Okay, wonderful. I would have wished for universal health coverage, actually. Yeah.
There are a lot of wishes.
Chale ji, oh hai? Achha, all right, wonderful. All of a sudden. So these were the three reasons why I thought that we should be having this topic. And this is UHC, and this is the public health crisis that we are talking about. So first and foremost, whether it is part of health ministry or not, our greatest problem is our population. And the population growth rate of 2 or 2 plus is the highest population growth rate in South Asia. And our total fertility rate, that is 3.6. Each woman, a mother in reproductive age, having 3.6 children on average, is static for the last 15 years. So first and foremost, our story of our problems actually begin with this. And we have about 9 million pregnancies each year, which qualitative research has informed us that there are 9 million pregnancies which were unwanted. Out of 9 million, 4 million were unwanted, which means that if we had provided them right information and right method of modern contraceptives, these 4 million pregnancies would have been avoided. Now, moving on, if we talk about this crisis in 3 groups, mother and child, communicable diseases, and non-communicable diseases, and mental health, I have just picked 4 for each one of them, and I'll very quickly rush through them. But how our mothers are. Women between 15 to 49 years of age, 42% are iron deficiency anemia, which is absolutely preventable. 154 of our mothers every 100,000 live births are still dying. Very high maternal mortality. Our neonatal mortality, that is chances of a child dying during first 28 days after the birth, is 40 every 1,000 live births, which is the second highest in the world. Only Lesotho, a sub-Saharan country, is ahead of us, and we are equivalent to South Sudan. And if we go deeper, through a differentiated data in Pakistan, the neonatal mortality of Balochistan is 68, which is the highest in the world. So when I call it crisis, I fully qualify to call it crisis. 37.6% of our children under 5 years of age are stunted, physically or mentally, or both. And if many of them are not treated within the first 3 years of the life, it is irreversible condition. So a big majority of these 40% of our next generation might be physically very weak, might be mentally handicapped, or have low IQ, and how they will contribute to the workforce of the future, how it will contribute to the productive economy or not. These are all questions I leave to your imagination. Coming to communicable diseases, we are the only 2 countries in the world we have not been able to eradicate polio. Our routine immunization, 23.5% of Pakistani children are not being immunized. And this figure, if we go to Balochistan, exceeds 70%. Hepatitis C, we have the world's one of the highest prevalence of hepatitis C. Tuberculosis, we have the 5th largest burden of disease in Pakistan. NCDs, every 4th adult above the age of 20 years in Pakistan is diabetic. Every 3rd adult above the age of 45 has high blood pressure. Our mental health problems are very diverse and very pervasive. Just to give you an idea, every 4th mother who is giving birth is actually also going through perinatal depression. And every 5th child in the school has some kind of behavioral or emotional problem. So I'm talking about those children who are in the school. Just to remind ourselves, we have 23 million children in Pakistan who are out of school. We cannot even research them because we cannot properly reach them. Most of these problems are preventable. In other words, my formulation of this is, if they are preventable, then somebody is responsible because they should have been prevented. So by this extension of logic, we can also say they are all man-made because they were preventable. So this is the breadth and the depth and the tragedy of the public health crisis then when I talk about public health crisis and why universal health coverage is so important. Next. Okay. This is, I will not go into the detail, but this is 2019 data about top 10 causes of death, causes of premature death in Pakistan, causes of years lived with disability by the living population, and the top 10 risks that people run when they move in our society to fall ill, and because of that, their life expectancy goes down. You can go through these later, but again, the point is that most of these problems and most of these risk factors are controllable, they can be checked, and they can be prevented, and people can be saved from them. Next, sorry. Okay. Let's come to our healthcare system, how we are responding to this crisis. So according to one estimate, we have a mixed healthcare system. We have public sector, we have private sector. According to one estimate, 70% of consultations, healthcare consultations take place in the private sector. 60% of all total health expenditures are made by people out of pocket, and most of it actually, whether they go to the public sector or the private sector, are actually spent in the private sector. Because वो नुस्खा लिख देते हैं तो आप दवाई ले लें जाके बाहर से, तो this is how it operates. And we don't even pay attention to this, but homeopathy and Hikmat and all other systems are very actually highly utilized systems in our society because of easy access to them and low cost. Now, when we talk about healthcare system, these are the kind of 6 important areas which make up any healthcare system: governance, health financing, service delivery, human resources, medicines, and technologies. Obviously, time does not permit me to go into the detail of each one of them, but just to highlight 2. If all these components on the left hand work harmoniously with each other, they can improve access, they can extend coverage, they can provide quality of care, and they can provide safety to the people, which will actually translate into better health outputs and health outcomes. But the reality is that we are not, despite of this public health crisis, we are also a country which is the lowest spender on health, as Dr. Razia Safdar in her introduction mentioned. We are the lowest spender in the South Asia, and we are equivalent to now many sub-Saharan African countries. Our health workforce is not planned according to our public healthcare needs in the country. And we are not managing our health workforce neither in terms of their mix, how many doctors, how many nurses, how many paramedics we need, nor we are being able to retain them in the system. So the result is that we are also passing through, I'm using the WHO terminology, one of the countries which has health workforce crisis, both in terms of quantity, quality, and mix and ability to retain them. I'm not even talking about the medical education that we are giving them. I'll talk about that in a minute. Now, it's not that government is not doing anything for universal health coverage. The government has actually developed, and actually ahead of many developing countries in terms of deciding priorities in health services, that if we have less resources, what should be our priorities in health services, and at what level of healthcare the government should be providing them. But that reality remain unchanged, that 70% of healthcare consultations still will be taking place in private sector, which is not very well regulated, to say the least. So we have this actually universal health coverage benefit package of Pakistan, essential package of health services. We have 88 health services that we have identified which must be provided at the district level, at the primary healthcare facility level, at the community level, and at the first level of hospital, first level hospital. And also, we have a wonderful program through which we are trying to provide the financial protection. You heard me saying financial protection being part of universal health coverage. It is also very much integrally linked with that policy of universal health coverage. Currently, this program is evolving and it will evolve further. Currently, I calculated this morning, 42.7 million families in Pakistan are covered with this, which makes, if we define family as family of 5, which makes 210 million people. It's not a small program, it's a huge program. And it is actually providing a lot of support to people, but only when they fall sick and they have to be hospitalized. So we wait for them to become sick so that we can provide them financial protection, because hospitals are expensive and people end up making catastrophic health expenditures. So that's why we have provided this cushion to people. But if you take a step back, the whole logic of this idea of waiting for people to fall sick and then treat them at a very high cost is also questionable, highly questionable. But nevertheless, this program is there because even if you are providing best of best prevention, people will still be falling sick. They'll still be needing appendectomies and C-sections and whatnot. So this does provide that kind of health coverage to the people. But this is only curative care and hospital admission care. Now, there is a calculus, a metric, which WHO and World Bank together have developed. We call it UHC, Universal Health Coverage Service Coverage Index. There are 16 index services or indicative services, and they use them to actually get an idea that how much coverage in any country people are getting in the name of universal health coverage. Of course, these are only 16 services, and even in Pakistan, I told you that we have 88 services, but these are indicative services. And these are some of those very basic things. Maternal and child health, we look at the family planning demand satisfied with modern contraceptive. We talk about antenatal care, at least 4 visits during the pregnancy. We talk about child immunization, 5 basic routine vaccines. 6? 5. Okay. Child pneumonia care, seeking behavior. In infectious diseases, we talk about TB care, HIV treatment, insecticide-treated nets for malaria prevention, at least basic sanitation. In non-communicable diseases, we talk about prevalence of normal blood pressure, normal blood sugar, basic things. I will stop reading all of them, but just to give you an idea that what are the basic things that we are using to judge and calculate that where a country stands in terms of its coverage of basic services. So with this introduction, and I'm sure my friend Dr. Raza Zaidi will talk more about it, but this is in 2021, our index, and this index is from 0 to 100. So Pakistan in 2015 was from 0 to 100 at the scale, we were 39.7 using these 16 services, same methodology. In 2021, we are 52. And we will get some latest details from Dr. Raza. And there is also a breakdown of all the provinces and territories of Pakistan. So it's not that we are not doing anything. There is also some improvement, but given the crisis that I have talked about, this is just not enough. And we need accelerated action to overcome the crisis that our people are living through. Somebody talked about primary health care. The health service research informs us that 72, and now WHO is saying up to 90% of the essential health care over the life course of a human being can be managed, provided at primary health care level. And this is community level, our basic health units, RHCs, first level hospital, in the public sector, and in the private sector, it's of course our GPs and small clinics, etc. The reality is, and I will show you in next slide, the reality is that in Pakistan, our allocations between different levels of healthcare are upside down. So 70% of our health budget almost is being spent on tertiary level healthcare in urban centers. And 30% is being spent on the primary healthcare, where the bulk of our population in remote areas, in rural areas where they live. Why this is so? This is not a rocket science to understand this very simple fact. Our indicators that I shared with you will never change if we do not strengthen our primary health care. But still 70% we spent on tertiary care. Why? Because it is convenient for rich living in big cities to easily go to the bigger hospitals and get their treatments. I always say that the organization of and our budgetary allocations to healthcare system is reflective of the elitism that we have ended up in creating in our society. That's just that. There is no other way of explaining this. So, अमीर लोग जो हैं वो अपने फायदे के लिए चीजें कर लेते हैं. Primary health care अब पाकिस्तान में इस तरह हो गया है कि it is a poor primary health care is equivalent to poor health care for poor people of Pakistan. So उसके बारे में ज्यादा फिक्र की जरूरत नहीं है. अगर हमारे बच्चों को इलाज ठीक मिल रहा है तो that should be enough. अच्छा जी. So 30% of our health we spent only public sector में हम 30% PHC पे खर्च करते हैं, primary health care पे 60% out of pocket expenditure private sector में है. और वो जो मैंने आपसे financial protection की बात की थी कि जिसमें we are only providing financial protection once somebody is sick enough to be admitted in the hospital and treated. उसके बगैर हमें होश नहीं आता कि किसी की सेहत जो है हमारे लिए इम्पोर्टेंट नहीं है कि हम उसके लिए उसको कवरेज दे सकें. और ये सारा क्राइसिस नीचे मैंने आपको बता दिया. So this is the context and this is the state in which we are in terms of our problems and in terms of some actions that the government is taking. We obviously still have to, aspire for comprehensive universal health coverage in accordance with the definition that I shared with you. How to make it possible? Let's ask our panelists. Thank you. तो अब मैं ही इसको मॉडरेट करूं जी, आप करेंगी?
Thank you, Dr. Zafar, for such a comprehensive and very informative presentation. So now over to you for the next panel discussion and to get some insights on the way forward for the universal health coverage. Thank you.
So thank you, Dr. Razia. And basically, I have raised a lot of red flags with reference to the situation that we are in. We have carefully selected our panelists for this session, and we will be asking them about what they have heard and what their own experience and expertise is, to share with us that how they look at the situation and how they think that we should, we have to higher the volume on this knob and lower the volume on this knob, what kind of policy package we should be thinking about in order to accelerate universal health coverage in Pakistan. So it's my pleasure, first of all, to request Dr. Safdar Suhail. Suhail Safdar Saab, you have already heard the introductions. I always look up to him when I have a question about social protection and anywhere. He's the expert. He has done PhD in this. And also he has been on very high bureaucratic positions in civil service of Pakistan. And still, he's a thinking man.
Well,
over to you, sir.
There's no occasion to react or protest on this backhanded compliment because I own my 37 years in civil service, and wherever one could, one has tried to do well, and a lot of our colleagues still in service, and I'll drag her also in this. She's also a public official. But Dr. Mirza has always been very kind, and I know of his passion to reform from the very first few months that he was given the responsibility to lead the reform process in the country. So that way I can very easily connect to his pained presentation of the whole situation, that we are actually in a very painful situation, and he has indirectly hinted that perhaps we are not doing all that one should do. And there I think he has explained what is wrong with our system. I'll go straight to the question of why is it happening? And are we unique in this? Is it happening only to us? And if this is not unique, then there's hope also. Because if it's happening to others, then others must be doing many things which we need to know. And maybe that would help us on that. But I'll just reiterate what Dr. Saab has just said about the significance of the topic. And now I think even now, if somebody does not read the signs of the terribly negative impacts on our labor market, I think that person is not sincere with the country. Our disability adjusted life years, our healthy life expectancy, all the colleagues who are doctors who are here. But there's another added element of significance or urgency, which is that our social protection system in general has fallen squarely flat. After this inflation, the monthly income transfers that we are giving to some poor people, we don't go into the details of exclusion errors, that is not even sufficient to put food even for 1/3 of the month for a poor household. Disability elderly, we never cared about them. We never bothered to bring work in the center stage of any social protection system. And we still have the audacity to call income transfers as social protection system. And here we are, that our current income transfer system has become the kind of Baitul Mal that we have since decades. So what can we do in terms of social protection in general has to be done in terms of health. If we can save our households from spending less on the kind of expenditures that are happening. So that for me is an added reason that we should be looking at that. Now, I personally study this sector as a services sector, and I will analyze it in the context of the liberalization of services sector. Liberalization of goods or merchandise we are having since so long, but the liberalization of services is a relatively new phenomena, but a continuous phenomena that we have. And conceptually, after you liberalize the services, you arrive at a stage what is called in the literature as market civilization, when the fast-moving consumer services reach every nook and corner of the country in every household, which is the case particularly after the social media. And the countries which do not distinguish between the liberalization of goods and services are the bookcase of the neoliberal paradigm, because that is one of the major difference that a lot of countries have liberalized with good results also. But one needs to be 100 times more careful while liberalizing the services. And we have not done enough care for that. So what has happened? The way we have liberalized our health sector at Social Protection Resource Center, which I'm steering these days, and we have friends like Dr. Arif Azad here who have been guiding us also on that. We initiated a study on the regional comparison of the patterns of liberalization of services, particularly health, on two major counts. The health professionals talk more in terms of financing, but we looked at the pricing and regulations in South Asia, because some of us are aware, or many of you may already know, that Pakistan these days is studied as a classical case of neoliberal paradigm. In South Asia also, and South Asians are learning from us in terms of saving themselves from the kind of results that Dr. Zafar Mirza has pointed out. Now, if you look at the pricing, what is happening? You presented, sir, the results, 60%, 70%. But if we look at the process which is happening, is the percentage of the profit margin between the total incomes of the health sector and the actual operating costs. Now in India, this is 1/3 to 2/3. That actual operating costs are 1/3 and the profits are 2/3 if we take it from 100. Now in Pakistan, this is 1/4 and 3/4. Now already 1/3, 2/3 is very high profit, and I don't find any other word but extractive profiteering for that. But if you look at the average in India for the total operating costs for the whole health sector and the total incomes, it is 6 times higher.
In Pakistan?
No, in India. In Pakistan, it's worse. So in hospitals, it is 1/3, 2/3. But if you take the whole sector, and there are some sectors which are terribly extractive and price gouging is there, particularly in diagnostic, for example, and many other areas. So in case of India, the total situation is that the profit motive is established beyond doubt. There are a lot of details, and I wish, Dr. Mirza, that at your university you initiate the research like this, that how is it happening here? What is the cost of private hospital consultation, bed, indoor treatment? For example, in Dawn, there was this news the other day that the pharmaceuticals are being sold at a very high price. But in India, this private sector sells the same medicine at 2.5 times higher. The same medicine, same company, everything is similar. Now, the second criteria for that we are using in this regional comparison is the quality of regulations. Now, the quality of regulation, we are using 4 primary criteria which are standard for assessing the quality of regulations. One is the balance between voluntary approaches and the mandatory regulations. I need not say anything more on that. We have PMDC. Doctors have tried to reform PMDC, and we know the results. The second is the effective coverage of different parts of health system. Now, if you look at the Punjab Commission, Health Commission website regarding the complaints, for example, there is a 0 complaint against labs and 1 complaint against hospitals. Now, this is counterintuitive. This cannot happen. That means your regulatory system is not working at all. If we have gone through the records of consumer protection courts in Pakistan, particularly in Punjab and KP, we don't have much happening. In India, they made consumer protection law in 85, they extended it to health in 95, and now they have a fairly good patient activism, which is there in consumer courts also. The third quality criteria that we have seen is the implementation effectiveness. The intensity of regulatory infrastructure in Pakistan is the thinnest or lightest in all of South Asia. As compared to Bangladesh, Sri Lanka, India, we are. And in terms of the fourth quality criteria, the citizen-centric, unfortunately, we are the worst again within South Asia. Now, what conclusions do we draw out of this is that health notions are rooted in socio-cultural settings of a society, which is there since long and which would, inshallah, continue. Pakistan's paradigm is the farthest from our own socio-cultural context of healing, what we call healing. We have replaced healing with sickness, and all of our healthcare system is focused on disease and then treating it with money. And as a result, we have this phenomena, which is there in all over South Asia. We are worse, but that doesn't mean that other countries are doing that well. This cream skimming is present in India also, that your private health sector provides services to the rich people, and they avoid difficult cases as well as the poor people. That is happening there also. Misleading advertisement, bait advertisements. We have regulations. If you the latest regulation that we have made is by Competition Commission of Pakistan on 23rd April 23, which is about advertisement, which captures all the issues that we have. If we do a reading of those, bait advertisement, switch advertisement, it does say that you should not sell, let's say, supplements which show children growing with formula milk or getting more intelligent and all that. But this is also an issue of implementation that we even our civil society do not take it seriously. So 3-4 main conclusions before I stop. One is that our conceptual understanding of the nexus between health, poverty, and trust in the society is bad or poor, and it's not anchored in any well thought out social policy. If I have time, I'll explain that. The second, that the fullermost success of the neoliberal model creates a situation when the system loses the capacity to self-reform, as the depletion or the hollowing out of the state capacity in itself had been the reform target. So this is a classical sign that you say that government should withdraw from it, so you hollow out the state capacity systematically. So when you need the regulation the most, the capacity of the state to regulate is the least. So now we are living in this situation that we need, right now is the maximum need of regulating, and right now our capacity is the minimum. So where do you go from there? In the last conclusion, with the deference and apology from the health professionals, which is an indication which is present everywhere, not only with us, the sectoral capitalist class are so self-absorbed that they lose sight of the interdependencies that their subsystem has with other subsystems, which is suicidal eventually. That's why you do not find the healthcare professionals taking interest in general economic development or in the control of external determinants of health, even in the preventive health. So this is a shell. This is an echo chamber where you discuss that. Very quickly, Dr. Sabha, I have got 5 recommendations I'll just mention. Number 1, merge public health with employee social security. You know where social protection resource stands on that. Patient-centric social health protection, activating the laws outside the healthcare system, such as Consumer Protection Acts, changing medical school syllabi, bringing in medical anthropology and different notions of the embeddedness of health-seeking behavior in the culture, regulate differently. This is all very well that you've said that primary care is important, but how do you regulate the primary care in the private sector I think it's very hard. It's better to not pin a lot of hopes there. Expanding social security employees institutions and merge them with public health infrastructure. And the final thought is that the challenge is to break the cycle of poverty, ill health, more poverty. We have stopped imagining a poor person healthy. Now, if we would not be able to imagine that in 15, 20 years' time, our labor market, our exports, our competitiveness would be in a very serious problem, and many more countries would be studying Pakistan as a classical country, which is not a failed state, which is a model of neoliberal policies. Thank you.
This was such a rich, conceptualization of the problem from social protection perspective. And you have given a lot of, thought about where things are going wrong and why some structural issues need addressal rather than just treating the symptoms of the situation. I really like this characterization of sectoral capital class. That's my pick. No, why you should apologize? I mean, that's how it is. That's what it is. And not only that, but our young health professionals, for them, this sectoral capital class act as a role model also. And that's how it perpetuates also. Anyway, moving on. Thank you, Dr. Sohail Safdar. Always end up learning more from you. Now we move to Dr. Raza Zaidi sir, a long-standing colleague and friend and very analytical mind, I must say, about health policies and health system and health situations. Very long-standing experience, and now one of the key people who is 24/7 working on national health policies and their how they can be better. So, Dr. Raza, my question to you will be that you have been working consistently over the years on essential health services packaging, and then you have been working on UHC index. So how you see, because you deal with a lot of data from different sources, so how do you see that where things are going wrong and how we can improve them to actually reach our own set target of the UHC index by 2030, which is 80 or 65?
80 plus.
80 plus. So over to you, sir.
Thank you. Okay. I'm sorry, but Dr. Zafar, if allow me, I will take 1 or 2 minutes to basically develop a clear understanding on the UHC. You have given a good explanation. Okay, what is UHC? But perhaps you were not that much open in explaining what is primary healthcare. Primary healthcare, we know that the concept started from Almata, and in Astana in 2018, concept was further refined and became more complex, I would say. And slogan for that is health for all. और अगर मैं इसको उर्दू में ट्रांसलेट करूं तो इसका मतलब है सेहत सबके लिए है. लेकिन जो यूनिवर्सल हेल्थ कवरेज का जो कॉन्सेप्ट है, दैट स्टार्ट्स फ्रॉम द WHO कॉन्स्टिट्यूशन. जब ये ऑर्गेनाइजेशन बन रही थी वहां से ये कॉन्सेप्ट चला था. ज्यादा रिफाइन हुआ 2004 में, 2012 में UN डिक्लेरेशन आया और 2015 में ये SDGs का हिस्सा बन गया. और UHC में और प्राइमरी हेल्थ केयर में क्या फर्क है? क्योंकि UHC को जब हम ट्रांसलेट करते हैं उर्दू में, इसका मतलब भी है सेहत सबके लिए. तो सेहत सबके लिए प्राइमरी हेल्थ केयर और सेहत सबके लिए UHC में हमें थोड़ा सा इसको पहले फर्क समझ लें, एंड देन आई विल ट्राई टू रिस्पॉन्ड टू व्हाट डॉक्टर जफर वाज सेइंग. तो फर्क सिंपल है कि हमने, जिसने डॉक्टर जफर और डॉक्टर रजिया ने कहा था, हमें 5 टाइप्स की सर्विसेज प्रोवाइड करनी होती है: प्रिवेंटिव, प्रोमोटिव, क्यूरेटिव, रिहैबिलिटेटिव और पैलिएटिव. यूनिवर्सल हेल्थ कवरेज में ये 5 टाइप ऑफ सर्विसेज हम 5 प्लेटफॉर्म से प्रोवाइड करते हैं, विच इज कम्युनिटी लेवल, पीएचसी फैसिलिटीज, फर्स्ट लेवल हॉस्पिटल, टर्शियरी हॉस्पिटल और पॉपुलेशन लेवल इंटरवेंशन। पॉपुलेशन से मुराद मेरी फैमिली प्लानिंग वाली नहीं है, पॉपुलेशन से मुराद है कि हम इस्लामाबाद में बैठ के एक मीडिया कैंपेन करते हैं, पूरी पॉपुलेशन को सर्विस प्रोवाइड कर देते हैं। तो ये 5 टाइप की सर्विसेज अगर आप 5 प्लेटफॉर्म से प्रोवाइड करें तो दिस इज कॉल्ड यूनिवर्सल हेल्थ कवरेज। आसान जबान में मैं बता रहा हूँ। ओके, ये तो हो गया। लेकिन अगर इस 5 टाइप ऑफ जो प्लेटफॉर्म्स हैं इसमें से मैं 2 प्लेटफॉर्म गायब कर दूं, विच इज फर्स्ट लेवल हॉस्पिटल और टर्शियरी हॉस्पिटल, इनको आप थोड़ी देर के लिए साइड पे कर दें और आप कहें कि मैं 2 काम और करूंगा। वन इज इंटरसेक्टोरल एक्शन, कि दूसरे सेक्टर्स के साथ मिलकर आप काम करें, और एक और चीज जो ऐड करनी होगी, दैट इज कम्युनिटी एम्पावरमेंट। अगर ये 5 चीजें आप करते हैं तो दिस इज प्राइमरी हेल्थ केयर। लेकिन ये दोनों बेतहाशा आपस में इंटरलिंक्ड हैं कि हमें अल्टीमेटली वो 5 सर्विसेज प्रोवाइड करनी है, चाहे वो पीएचसी से करें चाहे हम यूएचसी से करें। यूएचसी का जब कॉन्सेप्ट आता है तो इसमें हमें हॉस्पिटल्स को भी देखना पड़ जाता है, और फिर जिस तरह हेल्थ इंश्योरेंस की चीजें आती हैं तो ये इनिशियली टारगेट कर रही होती है मतलब हॉस्पिटल केयर सर्विसेज से, क्योंकि अगर आपने यू वांट टू हैव एंड ऑफ अवॉइडिंग प्रिवेंटेबल डेथ्स, आपको हॉस्पिटल्स पे जाना पड़ेगा। ठीक है, आप हेल्थ प्रमोट करें, क्यूरेटिव केयर करें, वो प्राइमरी हेल्थ केयर कर लेता है, लेकिन हमें किसी स्टेज पे हॉस्पिटल पे भी जाना पड़ेगा। अब पाकिस्तान जैसा मुल्क है, हमारे लिए क्या प्रायोरिटी होनी चाहिए? अगर हमारी सिचुएशन, फिजिकल सिचुएशन जैसे हमें पता है खराब है, तो हमारी टॉप प्रायोरिटी प्राइमरी हेल्थ केयर होनी चाहिए कि कम से कम जो बेसिक फैसिलिटीज हैं वो तमाम लोगों तक पहुंचाएं। और इसमें इंटरसेक्टोरल इसलिए जरूरी है कि हाफ ऑफ द योर बर्डन ऑफ डिजीज यू कैन अवॉइड थ्रू इंटरसेक्टोरल इंश्योरेंस। मैं हमेशा इसमें मिसाल देता हूँ कि डायरिया हो गया तो हेल्थ में आपने कहा कि अच्छा जी मैं ओआरएस निम्कोल दूंगा, लेकिन अगर आप इंटरसेक्टर में करें, लोगों को पीने का साफ पानी पिला दें, आप डायरिया पे जो पैसा जाया कर रहे हैं यू कैन उसको और किसी अच्छे मकसद के लिए इस्तेमाल कर सकते हैं। तो इंटरसेक्टोरल के बगैर हमें नहीं होगा। तो अगर पैसा नहीं है तो हमारी पहली प्रायोरिटी है कि प्राइमरी हेल्थ केयर को प्रमोट करें, चाहे वो लेडी हेल्थ वर्कर्स के थ्रू हो, चाहे वो वैक्सीनेटर्स के थ्रू हो, या बीएचओ आरएसी। और एक चीज और फर्क, चाहे वो प्राइमरी हेल्थ केयर है चाहे वो यूएचसी है, it is to be delivered both to public and private sector. ये मत differentiate क्या करें कि primary healthcare is the responsibility of public sector. No, 63% of primary healthcare services in Pakistan are being provided by the private sector, not by the public sector. आप कहेंगे ये क्या कह रहे हो? यहाँ EPI तो 100% तकरीबन आपका public sector कर रहा है। लेकिन जब आप बाकी सर्विसेज को देखते हैं, और इसमें WHO का एक टूल है, जब हमने इसको यूज किया तो हमें पता चला कि प्राइवेट सेक्टर इज प्लेइंग अ मेजर रोल इन प्रोविजन ऑफ प्राइमरी हेल्थ केयर सर्विसेज। वापस आते हैं सर, यूएससी इंडेक्स। अभी हम वी हैव जस्ट लास्ट मंथ वी हैव एस्टिमेटेड व्हाट इज द लेटेस्ट यूएससी सर्विस कवरेज इंडेक्स फॉर पाकिस्तान। इट इज 52.7, और इसमें पाकिस्तान का स्कोर हम ये सोच रहे थे कि शायद 54 के करीब हम पहुंचेंगे, लेकिन प्रॉब्लम ये हुई कि आपने अपनी आबादी 1 करोड़ बढ़ा दी एक सेंसस में, और हमें लेटेस्ट पॉपुलेशन यूज करें, मेजर डिनोमिनेटर है, जिसकी वजह से आपका स्कोर गिरा। आपका एक और यूएचसी में एक और इंडिकेटर है इंपॉर्टेंट है, जिसे बोलते हैं इंटरनेशनल हेल्थ रेगुलेशन इंडेक्स, कि आप हेल्थ इमरजेंसीज को कितना टैकल कर सकते हैं। वो स्कोर 53 था। नया टूल WHO ने इंट्रोड्यूस कराया, हमारा स्कोर 42.7 पे चला गया। अगेन मेजर ब्लो। इसी तरह कुछ और इंडिकेटर में उसमें तब्दीली की डॉक्टर जफर कह रहे थे 16 इंडिकेटर, अब ये 16 इंडिकेटर की बजाय जो ग्लोबल कम्युनिटी है उन्होंने इन इंडिकेटर की तादाद 14 कर दिया और कम कर दिया, लेकिन मेथडोलॉजी तकरीबन 4 ईयर रिजल्ट्स में इतना फर्क नहीं पड़ता। अब ये जो इंडेक्स निकालते हैं 4 एरियाज में, उसमें हमारी सबसे अच्छी परफॉर्मेंस जो है दैट इज ऑन RMNCH। इसमें इसका स्कोर 64.7 है। इसका मतलब है कि अगर हम थोड़ी बहुत और इन्वेस्टमेंट करें, या जो आपने आज तक पिछले ओवर लास्ट 2 और 3 डिकेड्स हमने काम किया है, अगर इसको कंटिन्यू रखें तो देयर इज अ गुड प्रोबेबिलिटी कि हम RMNCH में यूनिवर्सल एक्सेस को इंश्योर कर सकते हैं। इतना दूर नहीं है, 80 तक पहुंचा जा सकता है। सिर्फ जो सबसे बड़ी हर्डल है वो हमारी फैमिली प्लानिंग सर्विसेज हैं। अदरवाइज स्किल्ड बर्थ अटेंडेंस हो, इंस्टीट्यूशनल डिलीवरी हो, इम्यूनाइजेशन हो, हम 80% के करीब पहुंच रहे हैं। लेकिन हमारी जो सबसे खराब परफॉर्मेंस है दैट इज ऑन इन्फेक्शियस डिजीजेस, चाहे टीबी, चाहे वो HIV है, चाहे वो मलेरिया है, चाहे वो वॉश सर्विसेज हैं। इसकी वजह से हमारा जो इन्फेक्शियस डिजीज का स्कोर 41.7 है, हम बहुत दूर हैं हम 80% पे, हमें डबल इसको टारगेट को अचीव करना होगा, नामुमकिन है। एनसीडी पे हमारा बर्डन इस वक्त जो स्कोर है दैट इज 55.2, और उसकी वजह यह है कि अभी हम एपिडेमियोलॉजिकल ट्रांजिशन से गुजर रहे हैं। अभी हमारा मेजर बर्डन अभी भी आरएमएनसीएच और इन्फेक्शियस डिजीज है, लेकिन जैसे ही आप इसको कंट्रोल करेंगे, आपका ब्लड प्रेशर और डायबिटीज आपको दरवाजे को नॉक कर रहा है कि मैं आने के लिए तैयार हूं, और ये हर सिचुएशन खराब होने वाली है अगली डिकेड में। और सर्विसेज एक्सेस, जिसमें मुराद ये कि आपके हॉस्पिटल बेड्स कितने हैं, आपकी मेडिसिन अवेलेबिलिटी है, आपकी हेल्थ वर्कफोर्स कितनी है, या IHR कितना है। इसमें स्कोर 51.7 है, नॉट गुड, लेकिन इसमें ग्रेजुअल इंप्रूवमेंट ऑटोमेटिकली आ रही है और आएगी। तो दिस वर द स्टेटस। और इसको करने के लिए हमें क्या स्टेप्स लेने चाहिए हमारे लिए? तो पहला तो चीज़ है कि प्राइमरी हेल्थ केयर पे आप फोकस कर लें। लेकिन आप कहते हैं कि नहीं यार, इससे हम जो प्रिवेंटेबल डेथ्स है उसको हम प्रिवेंट शायद ना कर सकें, हमें हॉस्पिटल में जाना चाहिए। तो जो दूसरी ऑप्शन जो गवर्नमेंट देती है, दैट इज अबाउट डिस्ट्रिक्ट EPHS विद प्राइमरी हेल्थ केयर, कि आप अपने फर्स्ट लेवल हॉस्पिटल में फिर इन्वेस्टमेंट करें ताकि आप उनको वहीं पर डेथ्स को आप अवॉइड कर सकते हैं। और फिर तीसरी प्रायोरिटी, जो कि गवर्नमेंट वाज अ बिट एम्बिशियस ओवर द लास्ट डिकेड, कि हम लोगों को बेहतर टर्शियरी केयर भी प्रोवाइड करने चाहते हैं, लेकिन उसके लिए आपको और पैसे चाहिए। तो हेल्थ इंश्योरेंस प्रोग्राम इज ए गुड एग्जांपल कि वो UHCPSC में भी कंट्रीब्यूट करता है। लेकिन जब हम उसको देखते हैं तो हमें पता चलता है कि सिर्फ 2% ऑफ द पीपल आर एक्सेसिंग इंडोर सर्विसेज जो कि हेल्थ इंश्योरेंस में कवर्ड हैं। और रिसेंटली जब हेल्थ इंश्योरेंस की वैल्यूएशन KP में हुई है, तो उसमें एम्फेसिस किया गया कि आप इंडोर सर्विसेज को लिंक करें विद प्राइमरी हेल्थ केयर और OPD सर्विसेज। वाई? कि कैटास्ट्रोफिक एक्सपेंडिचर इंडोर में होता है, कोई शक नहीं, बिल्कुल हमें उसको कम करना है। लेकिन जब वो पेशेंट इंडोर सर्विसेज लेके जब वापस अपने घर जाता है, उसको एक रेगुलर ट्रीटमेंट की जरूरत पड़ती है और उसके लिए कॉस्ट पड़ती है, और वो कॉस्ट जो है वो हेल्थ इंश्योरेंस कवर नहीं करता। तो KP में भी आजकल ये बात हो रही है कि व्हाई नॉट हम हेल्थ इंश्योरेंस को लिंक कर दें प्राइमरी हेल्थ केयर के साथ, ताकि लोगों को कैटास्ट्रोफिक एक्सपेंडिचर जो है वो रिड्यूस करें। वो सिर्फ इसी तरह नहीं रिड्यूस किया जा सकता कि प्राइमरी हेल्थ केयर की सर्विसेज फ्री हैं, नहीं, आपको अपना प्राइमरी हेल्थ केयर को भी उसी मॉडल पे लेके जाना पड़ेगा जिस तरह के हेल्थ इंश्योरेंस का है, और हमें दोनों सिस्टम्स में सिनर्जीज क्रिएट करनी होगी। तो ये 3 ऑप्शंस हैं, और मैं फिर कह रहा हूँ ये पब्लिक और प्राइवेट दोनों को मिलकर करना पड़ेगा। सर मैं यहाँ पे रुकूंगा, लेकिन अगर आप प्राइवेट सेक्टर के रोल पे करेंगे देन आई विल कम बैक।
थैंक यू वेरी मच डॉक्टर रज़ा ज़ैदी। जस्ट वन रिफ्लेक्शन ऑन व्हाट यू हैव जस्ट सेड। ये जो इंडेक्स के फिगर्स इन्होंने आपसे शेयर किए हैं, ये नेशनल एवरेजेस हैं, और इसमें एक्विटी बहुत इम्पोर्टेंट एक डायमेंशन है, जो कि सिर्फ आपको डिफरेंशिएटेड डेटा की वजह से मिलती है। जिस तरह मैंने 2 दफ़ा रेफरेंस दिया बलूचिस्तान का जब मैं बात कर रहा था, यही फिगर्स जब हम बलूचिस्तान में ले जाते हैं, चाहे वो इम्यूनाइजेशन के हों, चाहे वो इन्फेक्शियस डिजीज़ के हों, तो फिगर्स जस्ट ब्लो अप। और हमारे यहाँ ये जो एक्विटी की डायमेंशन है हमारी सोशल सर्विसेज में, सिर्फ हेल्थ में नहीं, एजुकेशन में, और वही गोइंग बैक टू that fundamental issue that this country is actually divided between rich and poor, and the poor are at the receiving end of the worst services. That's what it is basically. तो अब हम चलते हैं जी, we have डॉक्टर अब्दुल गफूर शोरो। इनका इंट्रोडक्शन आप पहले ही सुन चुके हैं। ये इस वक्त पाकिस्तान मेडिकल एसोसिएशन के सेक्रेटरी जनरल हैं, इफ़ आई एम नॉट रॉन्ग, और ये इनसे हम बातचीत करेंगे कि डॉक्टर्स कम्युनिटी और PMA रिप्रेजेंट डॉक्टर्स स्पेशली। तो आप लोग PMA के तौर पे यूनिवर्सल हेल्थ कवरेज को कैसे देखते हैं, इसमें आपका क्या रोल है, और PMA का इस सिलसिले में क्या स्टांस है, और वो इस सिलसिले में क्या कर रहे हैं? इफ आई एम बिट प्रोवोकेटिव, आई वुड से कि इज इट जस्ट एन इंटरेस्ट ग्रुप ऑफ द डॉक्टर्स, या यू आर एक्चुअली आल्सो कंसर्न्ड अबाउट द हेल्थ केयर ऑफ द कंट्री? थैंक यू।
थैंक यू वेरी मच जफर साहब। मेरी आवाज आ रही है आप तक?
बहुत अच्छी आवाज आ रही है आपकी।
बहुत शुक्रिया आपका। बेसिकली वैसे तो प्रेजेंटेशन बहुत लंबी चौड़ी थी, लेकिन मैंने कोशिश की है कि आपको 5 मिनट में इस सबको समराइज कर दूं। जो जफर साहब का जो सवाल था कि पीएमए क्या कर रही है, उसके बारे में मैं कुछ कहना चाहूँगा। देखिए, ये यूएससी का जो एक मॉडल है वो तो आप सब लोगों ने बहुत ही अच्छा डिस्कस किया। जफर साहब के बाद तो मुझे बात करने की ज़्यादा ज़रूरत नहीं पड़ेगी। तो वो आपने तो बहुत ही अच्छी तरह से समझा दिया। बेसिकली पीएमए जो है उसका ज़्यादा फोकस जो है ना प्राइमरी हेल्थ केयर पे है। हम लोग कोशिश करते हैं कि जो सर्विसेज हैं वो हर लेवल पे प्रोवाइड करें, तो उनका एक प्लान बना हुआ है। पीएमए अपनी एक्टिविटीज कर रही है, और अल्हम्दुलिल्लाह इस वक्त हम कराची में और कराची से बाहर जो है ना तो फैसिलिटीज भी इस्टेब्लिश कर चुके हैं जो प्राइमरी हेल्थ केयर के लेवल की हैं। जिसका एक क्लिनिक का सेटअप है जिसका नाम ही है आम आदमी का क्लिनिक, तो वो आम आदमी को सर्विसेज प्रोवाइड करता है। दूसरा जो है वो गुज्जो में है, डिस्ट्रिक्ट ठट्टा में, रिमोट एरिया में है। उस पे भी हम जो है एएनसी पे काम कर रहे हैं, उसके साथ साथ जो है ना हम बाकी चीज़ों पे भी काम कर रहे हैं। इसमें बेसिकली जो डॉक्टर्स का रोल है, जिस तरह से आपने कहा कि डॉक्टर्स क्या कर रहे हैं या क्या करना चाहिए उनको, तो जो हमारे पास इंडिकेटर्स हैं, आपने खुद भी अभी कहा कि जो सबसे ज़्यादा खर्चा होता है वो प्राइवेट सेक्टर में ही लोग जाते हैं, वहीं से अपना इलाज कराते हैं, तो आउट ऑफ पैकेज जो जाता है उनका वो ज़्यादा है। तो पाकिस्तान में भी एक बड़ा बर्डन जो है ना वो पेशेंट खुद सफ़र करता है, अपने जेब से देता है। कुछ अर्सा पहले एक प्रोग्राम हुआ था जो बहुत ही अच्छा था, लेकिन वो भी शायद सेहत कार्ड जो है ना वो बंद कर दिया गया है। एक बात से मैं बिल्कुल आपसे जो है एग्री नहीं करूँगा कि जो टर्शरी केयर सेंटर्स हैं उन पे जो खर्चा होता है वो बड़े आदमी इसलिए करते हैं कि उनको फैसिलिटेट किया जाता है, वो अपने लिए करते हैं। सर ऐसा बिल्कुल नहीं है। वहाँ पे कुछ और चीज़ें होती हैं। जब करप्शन का बाजार गर्म हो तो ये थर्ड जो आपको टर्शरी केयर सेंटर्स पे खर्चा बहुत ज़्यादा होता है। जब किकबैक्स बहुत हो तो वहीं खर्चा होता है। आपने कभी भी ये नहीं देखा होगा कोई एमपी या एमएनआर टर्शरी केयर में गवर्नमेंट सेक्टर में जाके अपना इलाज कराए, लेकिन एक गरीब आदमी वहां भी जाता है, वहां भी प्राइमरी हेल्थ केयर के लोग जा रहे होते हैं। तो टोटल बर्डन जो है वो प्राइमरी हेल्थ केयर के साथ साथ सेकेंडरी और टर्शरी का भी उस पर टर्शरी केयर पे आ जाता है। बेसिकली हमें फोकस करना है प्राइमरी हेल्थ केयर को। 70% जो है ना हमारे कैटर करते हैं प्राइमरी हेल्थ केयर के फैमिली फिजिशियन है, जनरल फिजिशियन है। लेकिन उसके साथ साथ एक और भी आदमी है, वो ये है कि हमारे रेगुलेशन से अच्छे हैं लेकिन उन पर इम्प्लीमेंटेशन नहीं हो रही। तो आपको पता है पाकिस्तान के अंदर 6 लाख जो है वो कोएक्स भी काम कर रहे हैं, जो खुद इस हेल्थ केयर सिस्टम को और भी बुरा कर रहे हैं, बल्कि बीमारियों का बर्डन जो है बढ़ा रहे हैं। HIV को आप देख लीजिएगा, उसके साथ हेपेटाइटिस बी सी का जो रेशियो आपने खुद फिगर बताए बहुत ज़्यादा है, तो उनको देख लीजिएगा। कहने का मकसद ये है कि जितनी भी हमारे पास रेगुलेशंस हैं, जितने भी हमारे पास जो इदारे हैं, वो अगर प्रॉपर काम करें तो मेरे ख्याल में ये एक अच्छा सिस्टम बन सकता है। हम इसको हेल्थ केयर सिस्टम को अच्छा बना सकते हैं। सिंध में इस वक्त सिंध हेल्थ केयर कमीशन है, जो रिसेंटली एक नए जो कमिश्नर्स हैं, नई बॉडी बनी है, तो उन्होंने काम करना शुरू कर दिया है, और उम्मीद हमें यही है कि इस रेगुलेशंस पे प्रॉपर जो है ना वो एक्ट होगा, इम्प्लीमेंटेशन होगी, तो हमें कुछ अच्छे नतीजे मिलेंगे। पाकिस्तान मेडिकल एसोसिएशन इस वक्त भी जो है ना काम कर रही है इस पर, तो प्राइमरी हेल्थ केयर को फोकस किया जाए। रिसेंटली एक बड़ा इशू हुआ था, आपने अखबार पढ़े होंगे कि टर्शरी केयर सेंटर में जो है रोबोट्स वगैरह की खरीदारी का मामला था, और जिसपे अल्हम्दुलिल्लाह एक अच्छी बात ये थी कि हेल्थ मिनिस्टर साहब ने स्टैंड लिया और पीएमए भी उनके साथ थी, तो वो रुक गया, क्योंकि बहुत बड़ा जो है ना बजट वहाँ पे आप टर्शरी केयर में खर्च करने जा रहे थे। और प्राइमरी हेल्थ केयर का ये हाल है कि आपके पास एक्सरे मशीनें जो है ना वो भी नहीं है सेकेंडरी में भी, और आपके पास ORS के जो पैकेट नहीं है, आपके पास पैराडोल की टेबलेट नहीं है। और इंफ्रास्ट्रक्चर का भी हाल ये है कि जो है स्पेशली जो रूरल एरिया में लोग हैं उनके पास जो हॉस्पिटल में लेटरेंट्स जो नहीं है, तो ये बहुत बुरा हाल है। हमारा फोकस यही है कि जो रूरल एरिया में है स्पेशली, वहाँ पे एंटीनेटल केयर को देखा जाए, वहाँ पे जो है वो मदर्स का जो है वो फोकस किया जाए, यहाँ जो बच्चों की जो तरबियत की जाए अच्छी तरीके से, उनके जो ना जो 5 ईयर से कम लोग हैं, बच्चे हैं जो, उनके लिए प्रॉपर एक सिस्टम हो, न्यूट्रिशन पे ज्यादा फोकस किया जाए, तो मेरे ख्याल में हम बहुत सारे जो जाने बचा सकते हैं, बजाय इसके कि हम टर्शियरी केयर को ज्यादा फोकस करें या सेकेंडरी को ज्यादा करें। तो हमारे यहाँ जो काम है, अल्हम्दुलिल्लाह पीएमए हर फ्रंट पे कर रही है। हमने बहुत सारे डॉक्टर्स की ट्रेनिंग भी की है, उनकी जो है ना एक कैपेसिटी बिल्डिंग जो है उसमें किरदार अदा किया है। तो पीएमए का जो आपने एक लफ्ज कहा था कि वो सिर्फ जो है ना अपने बेनिफिट्स के लिए काम तो वो नहीं करती, पीएमए कम्युनिटी के लिए काम करती है, और बेसिकली हमारा स्लोगन भी है कि हम जो है ना पेशेंट फ्रेंडली ऑर्गेनाइजेशन। बहुत शुक्रिया,
थैंक यू डॉक्टर सौरभ। अच्छा जी, अब टाइम की थोड़ी कमी है, लेकिन आई वुड लाइक टू ओपन द फ्लोर फॉर हैविंग सम गुड डिस्कशन। तो 5 to 7 questions I think we will be able to accommodate. ठीक है, इजाजत है? चले 4.5 कर लेते हैं। चलें, क्योंकि ये बड़ी इम्पोर्टेंट मेरा ख्याल है डिस्कशन हुई है और बड़ी पुरमगज बातें हुई हैं यहाँ पे, और मेरा ख्याल है कि बहुत यूज़फुल होगा कि हम अपने जो पार्टिसिपेंट्स हैं जो हमातन गोश थे, मेरा ख्याल है सो नहीं रहे थे, तो उनसे भी हम सुने। आप अपना तारुफ भी करवाएं और सवाल भी करें।
आवाज नहीं आ रही।
Sure. So I work on inclusive health insurance, and first of all, I mean, it's amazing to have such a brilliant discussion here. So and a disappointment that this was not represented by any insurance sector apart from me. I'm like a teeny weeny. So in terms of I mean, there are two really aspects I would like to discuss, and it's a question really. So one is that what role do you see in of private sector in universal health cover? The second is so our federal government, we start our year with a deficit, right? And the other area I work on is climate risk insurance. So again, everyone points to the state, and state is practically bankrupt on day one, right? So when you start off your fiscal year, you have negative. And I have alerts on this sehat card and all. So every day I get alert, Google alert, KP mein khul gaya, band ho gaya, khul gaya, band ho gaya. And the latest is that they are reducing it down to 20% bottom of the pyramid, which is good. Give to 2% or 1% of the population, but keep doing that. Don't like switch off, switch on. So my question is that is it a pipe dream for a country like us that we're gonna have state-sponsored free healthcare for everyone? Is it like an election slogan, or it's a reality? And if we have example from other parts of the world where private sector and public-private partnership actually able to create a robust and sustainable UHC? Thank you very much.
Thank you. हम क्वेश्चंस और भी ले लेते हैं और फिर उसके बाद जी प्लीज।
Assalamualaikum. A very good evening to everybody. मेरा नाम डॉक्टर रुबीना फरीद है, and I've been in private practice for the last almost 30 years. Honestly, it's still very sad to know what 30 years back जो condition थी उससे worse हो गई है. I'll just quickly give 4 suggestions because there's a lot to talk about the sad things. One was that I've been, working for Family Planning Association of Pakistan. Almost 10 years we worked. And only year which was successful was when we gave door-to-door facilities. That was the only year. Otherwise, खुद से लोग हमारे पास नहीं आ रहे थे. Second suggestion is कि please, when you make your policy, include post-menopausal women into it. See, now the post-menopausal age average is 48 and life expectancy 78 होगी. तो वो 30 years बेचारी औरतों को कोई नहीं पूछता, कहीं उनको include नहीं किया जाता, their mental health, their physical health. Third thing is the disabled women mostly. ठीक, mostly disabled, उनके लिए बेचारों के लिए भी कुछ भी नहीं है. और चौथी मेरी suggestion है for the infertility. For example, if एक औरत के tubes बंद हो गए हैं and she cannot produce children, तो government is not giving any facility to them. It's private practice. Private में it's so expensive. Everybody knows that. So these 4 things should be included in our policies.
Thank you very much. आपकी question नहीं था बल्कि suggestions थी, which are useful points, very useful points. Any other जी?
Very briefly. It's okay.
No, it's not okay because they will not be able to hear.
Sorry. Hello. Does it work? Does it work?
Yeah, okay. Sorry, Dr. Mirza, you mentioned UHC service coverage index. Excuse my ignorance. You know, who collects these national level data? And the other thing is trends. If you look at the 2015 data and compare it to 2023, trends are positive. They are in the right direction. So we can just focus on that and improve it more. Thank you.
Okay. All right. Apne haath uthaya tha. Ji. For last 2 points we will say. Ji.
Thank you very much. My name is Dr. Qaid Saeed and I'm the Chief Executive Officer of Islamabad Health Care Regulatory Authority. I think I've been also working at the federal level and working very closely with the ministry for the last several years. I see this universal health package and the policies that are being developed, but never translated into actions. And then after devolution, what I see is that the promises are not entrusted. Rather, they think that a national policy is something not for them, and they are towing their own line. Now, if you are talking about a universal health care package and the essential health services and the primary health care services that we want to strengthen through a policy at the federal level, where the provinces are totally doing their own policies and implementations, how do you think that we are going to actually implement the universal health coverage that we want to implement in next 7 years?
Okay. He's the man who is responsible for regulating the private health sector in Islamabad. If you have any doubt or any complaint, he's the man.
Sajda Naseem, and I'm heading the Department of Community Medicine, Shifa. So my question to the panel is, because Safdar Saab also mentioned about the PMDC regarding that. So has there been a thought given to like revisiting the curriculum? Because nowadays we are seeing it is not being related with public health, and we see we're talking about the public health crisis. So I think a major step needs to be taken in that at least doctors should know what they are supposed to deliver. So that's, thank you.
आपसे तो मैंने वैसे भी मिलना था, उससे अच्छा है इस तरह मुलाकात हो। जी, last बात जी। Planning.
Yes, thank you, sir. My name is Dr. Shamrit. I'm Assistant Chief at Health Section. Planning, sir. We are currently, in the process of approving the Sehat Sahulat and other projects, and we have seen that, universal health insurance, it seems like the component of financial protection in the UHC. Is it the UHI is financial protection for universal, or is it a bit different than that? So
it's interesting. Planning is asking this question. That's very interesting. That's very interesting. Very telling, actually. Sir, जी अर्शद साहब, डॉक्टर साहब लाबा अपने प्रोग्राम की तारीफ करने के क्वेश्चन करिएगा।
सर, तनकीद करने वाले इतने, कोई तारीफ करने वाला भी होना चाहिए। तो बट आई जस्ट विश टू गिव कुछ अच्छी बातें बता दूं, और कुछ चीज़ें जो हमने जफर मिर्जा साहब जो मेरे बॉस भी और मेरे मेंटोर भी हैं, उनसे हमने जो सीखी भी हैं, देखी हैं। Being an actual practitioner and head of the National Universal Health Insurance Program, there are so many silver lines in the cloud, to be very honest, not being biased. I will go very briefly. एक तो ये कि 25 करोड़ पाकिस्तानियों में से 20 करोड़ पाकिस्तानियों को हमने यूनिवर्सल हेल्थ इंश्योरेंस में कवर कर लिया है. We are one of the largest national universal health insurance program on this earth. Secondly, the remaining province only federating unit Sindh is at an advanced stage, which we already reached 60% on this introduction of the universal health insurance for inclusion of Sindh. Then we'll be 250 million nation. और मैं एक अच्छी खबर सुनाना चाहता हूँ खासतौर पे मिर्जा साहब को, क्योंकि मैं उनसे बड़ी इंस्पिरेशन लेता हूँ खासतौर पे पीएचसी के ऊपर. एंड आई एम आल्सो ए चैंपियन कि जनाब प्राइमरी हेल्थ को जोड़े बगैर यूनिवर्सल हेल्थ इंश्योरेंस जो कर रही है सेकेंडरी और टर्शरी केयर में, वो हो नहीं सकता. बिकॉज आई बीइंग ए मैनेजर ऑफ दिस प्रोग्राम have a selfish interest, being the government of Pakistan, to save the life at the early stage and to save the money at the later stage. And PSC is the only magic only magic which can make it possible. अच्छी खबर सर ये है कि सिंध में हम जो लॉन्च करने जा रहे हैं यूनिवर्सल, डे 1 से हम PHC इंटीग्रेट कर रहे हैं. The reason being that Sindh is the only province which has a relatively functional through PPHI and other model. We can immediately integrate because our program is fully digitalized. We'll integrate this primary component with our program. So directly a seamless referral will go to the secondary care and tertiary care. And just one thing more, अक्सर आपने सुना होगा, बहुत से लोग ये मतलब ये गाना बजाना बहुत ज़्यादा सुनता हूँ, बहुत हर फोरम पे ही कि जी how sustainable is the universal health insurance program? Can we afford this luxury? Even Ahsan Iqbal, when we met with the change of the government, the first question he said, Arshad yaar G7 नहीं afford कर सकता, can we? And I said yes, we can. It's all about rechannelizing the resources. 1200 अरब पाकिस्तान का इस माली साल का पब्लिक हेल्थ बजट है. मैं सिंध को भी शामिल कर लूं, जो मेरा टिकट प्राइस है वो 225 अरब का है. Less than 18% of Pakistan's current public health budget. If I can give a peace of mind to whole of my nation to get rid of secondary care and tertiary care pain, जो कि जिस्मानी तबाही का भी और माली तबाही का भी बाइस बन सकता है. This is a win-win deal for everybody. Still we have 1000 billion. Please आप PSC में लगाएं और जहां मर्जी लगाएं. And last thing, कि और ये कितना पाकिस्तान में रिसोर्सेज की कमी नहीं है. टू बी ऑनेस्ट आई कैन विटनेस कि देयर इज नो रिसोर्स की कमी है, ना अच्छे लोगों की कमी है. व्हेन आई वाज जस्ट हैविंग अ सेशन लास्ट वीक विद द सिंध हेल्थ मिनिस्टर, वो मुझसे कहने लगे अरशद यार ये तो बताओ ये मेरा टिकट प्राइस बनेगा कितना सिंध का अगर यूनिवर्सल हेल्थ इंश्योरेंस पर चला जाऊं. मैंने कहा जी रफली 35 to 40 billion rupees फॉर ऑल सिंध पॉपुलेशन. आर यू श्योर अरशद? मैंने कहा यस आई एम प्रीटी श्योर, आई एम वर्किंग दीज नंबर्स एवरी डे. अरशद कैन यू बिलीव I'm paying 89 billion rupees grant to charity hospital from Sindh government every year. Just with the only 45% of this grant, if I can provide a universal health insurance to every Sindh population, it is very easy. So this is how actual things and actual insights are working on ground. Thank you.
Thank you. Thank you very much.
ये मैं गुजारिश करता हूं आपको वेरी क्विकली मुझे अंदाजा टाइम की कमी है. एक ये कि केपी इज द ओनली प्रोविंस जहां इंटरम गवर्नमेंट थोड़ी सी फाइनेंशियल मैनेजमेंट का शिकार है, क्योंकि रिसोर्सेज फेडरल से नहीं आ रहे. तो बीच में जैसे वो एक और भी कोलिग कह रहे थे, पॉजेज आ रहे हैं बीच में. जी बाकी जो है हमने पहले दिन से जब यूनिवर्सल हम करने गए थे, मिर्जा साहब उस जमाने में हमारे बॉस थे, उसके बाद फैज सुल्तान आ गए, हमने प्राइम मिनिस्टर को ये कहा था कि the affordable segment should give some kind of contributions to make it sustainable. उस वक्त for political reasons, being a political economy project, ये हमें इजाजत नहीं मिली. But I being a professional, हमें तो सही बात उनको बतानी थी. अब now we get a window. Now we are introducing a co-payment for 30% of the actual treatment from upper 70% population when they will go to the private hospitals.
Excuse me, I happen to be the chair of this meeting. So we have to wind up. I'm sorry. इनको लेकिन पकड़ लें आप, इनसे डिस्कशन करें बाद में. अच्छा, बहुत सारे यूजफुल पॉइंट्स आए हैं, but I would before going to our chief guest General Nigar Khan, I would like to give 2 minutes each to all the panelists to have an opportunity to respond to some of the points that they have heard. और उसके बाद फिर मैडम के पास आएंगे. जी.
Thank you, sir. Very quickly. जो एक सवाल था रोल ऑफ प्राइवेट सेक्टर इन यूएसए, मैं इस पे अभी आता हूँ, लेकिन उससे पहले जो डाटा है, ये डाटा कहाँ से आता है? मेथोडोलॉजी वर्ल्ड बैंक और WHO ने years of fight के बाद इस पे एग्री की थी. The same methodology we are using. डाटा हमें कहा जाता है कि कहाँ से कलेक्ट करना है. कुछ के लिए हमें डेडिकेटेड सर्वे होते हैं जिस तरह PDHS सर्वे है, कुछ के लिए स्पेशलाइज सर्वे हैं जिस तरह स्टेप वाइज है, गैट सर्वे है. कुछ हमें जो एडमिनिस्ट्रेटिव डाटा है रेगुलेटरी बॉडीज का, PMDC है या हेल्थ केयर कमीशंस हैं, वो हमें ये डाटा प्रोवाइड कर रहे हैं. और इसी तरह कुछ डाटा जो है वो हमें जो गवर्नमेंट के इंफॉर्मेशन सिस्टम है जिस तरह HIV TB है, क्योंकि ग्लोबली भी ये डाटा वहीं जा रहा है तो उसको यूज करें. तो ये रिलायबल डाटा है, इसमें हमें कोई शक नहीं. लेकिन ये डाटा यूज करते हुए हम यूएससी सर्विस कवरेज इंडेक्स ना सिर्फ नेशनल पे कर रहे हैं बल्कि प्रोविंसेस पे कर रहे हैं, बल्कि हर डिस्ट्रिक्ट पे भी कर रहे हैं। और हर डिस्ट्रिक्ट का स्कोर हमारे पास 2015 से आज तक है। इसकी इन्फॉर्मेशन अगर कभी आप मिनिस्ट्री ऑफ हेल्थ की वेबसाइट पे जाएं तो वहां से भी मिल जाएगी, नहीं तो आप हमसे कॉन्टेक्ट करें, हम आपको ओरिजिनल डाटा भी देने के लिए तैयार हैं। लेकिन इसमें याद रखें कि हमें ग्लोबली कमिटमेंट हमारी है कि हमने 80+ पे जाना है, लेकिन हमें पता था कि हम नहीं जा सकेंगे। जब हमने एसटीजी को लोकलाइज किया नेशनल और प्रोविंशियल लेवल पे, हमने कहा हम 65 पे भी चले गए बाय 2030, इट इज गोइंग टू बी अ बिग अचीवमेंट। और जिस तरह आपने बताया कि हम 40 से शुरू हुए थे 2015 में, इस वक्त हम 53 के करीब आ चुके हैं। क्या हम 65 पे जाएंगे? आई डोंट नो, ये डिपेंड करता है कि फ्यूचर में गवर्नमेंट कितना इन्वेस्ट करती है। सो दैट इज अबाउट द डाटा। लेकिन एक चीज और, 65 जब आपका टारगेट है तो पाकिस्तान का सिर्फ एक डिस्ट्रिक्ट है जो इसको एक्सीड किया है पिछले साल टू 2022। एनीवन जो बता सके? नो, इट इज कराची साउथ, क्योंकि वहां पे आपके बेतहाशा बेहतरीन अस्पताल है। दूसरा डिस्ट्रिक्ट जो है वो लाहौर है, तीसरा एबटाबाद है, और फिर बाकी जो इस तरह आने शुरू करते हैं। इस्लामाबाद का रैंकिंग 9 था अमंग प्रोविंसेस, इसका स्कोर सबसे ज्यादा है, लेकिन अमंग डिस्ट्रिक्ट्स इसकी रैंकिंग 9 से 12 पे चली गई है, क्योंकि कुछ डिस्ट्रिक्ट्स जो है ना वो अपनी परफॉर्मेंस बेहतर दिखा रहे हैं। बट इट वेरी इंटरेस्टिंग कि अगर आप देखना चाहते हैं कहाँ पे हो रही है, जो डॉक्टर जफर कहते हैं कि एक्विटी कंसिडरेशन करनी हो, तो रिव्यू दिस रिपोर्ट्स, और हम थोड़े छोटे ब्रीफ और ब्रोशर भी बना रहे हैं ताकि आपको समझने में उसको आसानी हो। एक चीज वर्स्ट आप जानते हैं कि कहाँ होंगे इंशाल्लाह, वो हमारे बलूचिस्तान में। बलूचिस्तान का ओवरऑल स्कोर भी जो है वो इस वक्त भी जो है वो 40 से कम है, 38 लाइक इस तरह करके है। जबकि इस्लामाबाद का इस वक्त 58 पे चला गया हुआ है, पंजाब 53 के करीब है। तो एक चीज और से जो आपने जो सवाल किया था कि रोल ऑफ प्राइवेट सेक्टर क्या होना चाहिए। रोल ऑफ प्राइवेट सेक्टर जो ऑप्शन है, मुख्तलिफ मॉडल जो प्रपोज कर रहे हैं, उसमें यह है कि ये टाइम आ गया है कि हमें गवर्नमेंट से रिस्पॉन्सिबिलिटी हम अपने जीपीस की तरफ शिफ्ट करनी पड़ेगी, खासतौर पे अर्बनाइज्ड डिस्ट्रिक्ट्स में। अर्बनाइज्ड डिस्ट्रिक्ट्स में गवर्नमेंट को अपनी इन्वेस्टमेंट को कम करके इसको डाइवर्ट करना पड़ेगा रूरल एरियाज की तरफ, ताकि वहां पर हमें पता है कि वहां पे डॉक्टर्स नहीं जाएंगे। लेकिन अर्बनाइज्ड डिस्ट्रिक्ट्स जहां पर जीपीस मौजूद हैं, उनको स्पेशलाइज्ड ट्रेनिंग देनी पड़ेगी और उनको गवर्नमेंट को इंसेंटिव प्रोवाइड करने होंगे कि पेमेंट सिस्टम लाना पड़ेगा कि अगर आप ये एसेंशियल पैकेज डिलीवर करते हैं, हमारे पास इस वक्त सारी कॉस्ट एस्टिमेट है, हमें ये भी पता है हम कितना रिजल्ट अचीव कर सकते हैं अगर ये इन्वेस्टमेंट करते हैं। तो उनसे कोई कंपटीशन कराएं जीपीस का कि आए जी, ये यूनियन काउंसिल है, यहाँ पर हमें एक जीपी चाहिए जो इस पॉपुलेशन को सर्विस प्रोवाइड करेगा, इतनी कॉस्ट होगी, ये रिजल्ट आए, हमसे डायलॉग करें। अगर इस किस्म की अप्रोच हम ले आए तो हम अर्बनाइज्ड डिस्ट्रिक्ट से यूएचसी को अचीव करना शुरू करेंगे। और इन द मीन टाइम गवर्नमेंट की इन्वेस्टमेंट अगर हम रूरल में ले जाएं, इट कुड बी वन ऑफ द पॉसिबल ऑप्शन, और इसके अलावा और ऑप्शंस भी हैं। लेकिन जो एक और जिसके साथ लिंक है, मैं फिर कह रहा हूं कि अगर हेल्थ इंश्योरेंस को पीएचसी के साथ आप लिंक नहीं करते, बोथ पब्लिक और प्राइवेट सेक्टर के थ्रू, आपका जो यूएससी अचीव करना है वो भूल जाएं, फिर हम अचीव करेंगे।
थैंक यू रजा, इट वाज अ वेरी कॉम्प्रिहेंसिव रिप्लाई। और मैं भी बिलीव करता हूँ इसमें कि इसके बारे में बहुत ज़्यादा सिनिकल होने की ज़रूरत नहीं है। देयर आर कंट्रीज who have actually done it through public sector, health being the responsibility of the state. तो private sector के साथ collaborate करते हैं आप, और उनसे strategic purchasing is the best way to regulate them. This I have understood in my as a student of health system. सिर्फ regulation नहीं, रेगुलेशन भी आप जाहिर है उस करनी पड़ेगी, लेकिन जब आप उनको इंश्योरेंस सिस्टम के अंदर लेके आते हो तो दैट्स द बेस्ट वे टू आल्सो रेगुलेट देम। अच्छा, अब मैं डॉक्टर सुहेल सफ्तर साहब से रिक्वेस्ट करूंगा, सर इसमें जरा थोड़ा सा अगर आप ये भी मेरा भी एक क्वेश्चन शामिल कर लें कि प्राइवेट सेक्टर की हम बहुत बात करते हैं, व्हाट इज द इंसेंटिव फॉर द प्राइवेट सेक्टर। हम प्राइमरी हेल्थ केयर एज ए ब्रैकेट तो कह देते हैं, लेकिन प्राइवेट सेक्टर का एक बहुत बड़ा कंपोनेंट प्रिवेंटिव हेल्थ केयर है। व्हाट इज द इंसेंटिव फॉर द प्राइवेट हेल्थ केयर to invest in preventive side of the healthcare?
Yeah, thank you very much. The main question, role of private sector. I think we are not in the beginning of a process of reform that we should pose these questions. We are in an advanced stage of experimentation of giving responsibility to the private sector And now is the time to do quality studies on the behavior of the private sector in different segments of healthcare delivery. I would say that let's take army as we used to take the example of agricultural university forms as a standard and then measure the productivity of the ordinary farmers corporate. Why has army not gone for the financialization of health services? What are their costs? What is their governance? And where is, I have gone into the regional comparisons. In that context, rhetorically वक्त आ गया है कि जी आप ये जरा रुकें यहाँ पे और देखें कि हो क्या रहा है और ये बिहेवियर जो है ये देखिए हमने कभी प्राइवेट सेक्टर को उस तरह से उसकी एक्सटर्नैलिटीज पे रेगुलेट ही नहीं किया. हमें उनकी पावर का अंदाजा नहीं है, हमें उनकी जो कैपेसिटीज हैं टू थ्वाट सीरियस रिफॉर्म वो हमने टेस्ट ही नहीं की हुई. तो वो हमने तो पहला कदम उसका नहीं लिया हुआ है. इफ यू आस्क मी, फाइनेंशियलाइजेशन जो है वो थर्ड वर्ल्ड कंट्रीज का एक्सपीरियंस जो है वो पाइप ड्रीम की तरफ चला जाता है. आप ले आए प्राइवेट सेक्टर प्राइमरी केयर को, बट चेंज द रूब्रिक. आप एम्प्लॉय सोशल सिक्योरिटी हॉस्पिटल में भी तो आफ्टरनून में अलाउ कर रहे हैं ना प्राइवेट प्रैक्टिस, आप बड़े हॉस्पिटल में भी कर रहे हैं. ब्रिंग देम इनटू अ सेपरेट कैटेगरी वेयर दे बिकम पब्लिक ऑफिस. देखिए आप कान को उधर से पकड़ने की बजाय व्हेन देयर इज a primary healthcare provider who is doing business on government's money, why do you still insist to call it private sector? Simple. तो उसमें voluntarily लोगों को लेके आए. If a good number of people become family physicians and primary healthcare providers with the government's money, then you should have a separate PMA for these doctors, which then take care of the basics that you talked about in that sense. So there, I think the last thing which I would say is that, an emphatic experience says that in a state which is very weak in regulations, you must stop promoting private sector, stop looking at that, and identify strategic areas where state still has some capacity to recover some of the space, maybe in diagnostics, maybe in pharmaceuticals. Then I think we would have some space, and there the kind of models that our military, for example, presents, they can lead us. So why not select a few districts for this kind of experimentation? We are talking about national policies. Let's do it in Islamabad, for example. If the Islamabad Regulatory Authority can come up next year with a report that today this is the behavior of the profit gouging of the private sector, and with my interventions, I've listed 4. In 1 year, this behavior has gone from here to here. Then I think we can have some kind of confidence in regulatory authorities. Otherwise, I'm not very optimistic.
This should be the subject of next seminar, actually, because it is actually indeed very interesting. Shoro Saab, Dr. Shoro?
Yes.
1 minute, please. Any आखिरी ख्वाहिश?
ख्वाहिश सर बहुत है, हर ख्वाहिश पे दम निकले, लेकिन थोड़ी सी जो प्राइवेट और पब्लिक सेक्टर की जो बात हो रही है उसमें हमारे पास सिंध में एक पीपीएच है और कुछ जो सेंटर्स काम कर रहे हैं, उसमें गवर्नमेंट की जो और थोड़ा सा इनमें डिफरेंस है. जैसे कि उन्होंने प्राइवेट और पब्लिक पार्टनरशिप पे काम शुरू किया है, तो गवर्नमेंट के जो वही सेंटर जो है वो 41% पे काम कर रहा था, आज वो 73% पे काम कर रहा है. इसी तरह से उसके इक्विपमेंट जो है ना उनकी हालत नहीं बुरी थी, वो 38% पे थे, वो इस वक्त 75 पे कर रहे हैं. ड्रग्स जो है ना वो 51% पे थे, तो 87% पे है. सर्विस डिलीवरी स्टैंडर्ड जो है ना 8% थे, वो इस वक्त 69% है. स्टाफ की जो सेटिस्फेक्शन रेट था वो 59 था, अभी 70 के करीब है. डायग्नोसिस जो है वो 12% से 39% चली हुई. रिकॉर्ड कीपिंग का 65 से 83 पे. कहने का पूरा मकसद ये है कि जो हमारे यहाँ प्राइवेट सेक्टर में कहते हैं ना कि वो, जैसे डॉक्टर रजा ने बहुत अच्छी बात की कि जो जीपीज को एक नेटवर्क में लाएं और फैमिली फिजिशियन को आप प्रमोट करें, तो मेरे ख्याल में हमारे पास ये टूल है तो हम यूएससी को हर जगह पे अप्लाई कर सकते हैं और इसका जो बेनिफिट हमारे सोसाइटी पे बहुत अच्छा होगा और प्लस हमारे कवरेज भी बहुत अच्छी होगी. थैंक यू वेरी मच.
Actually, when we were talking about and discussing the title of this, you would remember of this event. So, एक suggestion ये थी कि we also perhaps title it as how we should envision a national health service. Actually, because universal health coverage, public sector being limited, need for collaborating and going into public-private partnerships, ultimately you end up actually developing a nexus of a national health service. And that's perhaps maybe next time we should be discussing that. It's my great pleasure, Naoji, to invite Lieutenant General Nigar Johar Khan. I had privilege to very briefly work with you also during the COVID-19 because it was a great experience also. पहली दफा पाकिस्तान में ये तजर्बा हुआ था कि आप पॉलिसी बनाते हैं वो इम्प्लीमेंट भी हो सकती है. Within 24 hours, we used to implement things and get feedback. And this was because the platform that we created, as we call it, NCOC, and Lieutenant General Nigar was behind the scenes supporting all that. Over to you, Dr. Sabha. आप बताइए कि आपके क्या ख्यालात हैं इस सब्जेक्ट के बारे में जो आज हमने डिस्कस किया.
Thank you very much. So, starting with Bismillah ar-Rahman ar-Rahim, Professor Dr. Zafar Mirza, Dr. Safdar Sohail, Dr. Raza Zaidi, Dr. Razia Safdar, and August audience. Assalamu alaikum. I feel honored and privileged to be here on this podium, and especially in front of such intellectual audience and the speakers and the presenters. So my gratitude to Razia Safdar and all the organizers for having me here. Thank you very much. And as you all know, before I start with anything, I would definitely acknowledge SPDI for their focus on universal health coverage and their role and their efforts for it. And of course, they are spreading the message and making it happen. And then I would also compliment all the presenters and the speakers and, of course, the iconic Zafar Mirza also, and Safdar Sohail, Raza Zadi, and every one of you for such fruitful discussions that we had here. And there were some new things for me also, and I really enjoyed listening to all the discussions. So if I talk of the universal health coverage, it has been already elaborately given to us by Dr. Zafar Mirza. To me, simply it is all health services for everyone, everywhere, without financial hardships. So we are all focused on it, and seeing all the scary statistics that Dr. Zafar Mirza gave to us, with the second highest neonatal mortality, infant mortality, and then the fifth highest maternal mortality rate of the country in the whole of the world. Yes, we can all easily say, and we already know that the health services and health system of Pakistan is weak, and we have to improve it. Unless and until we accept the actual facts, we are not going to do anything about it. And we are here to do all those things, and we are already focused on it. So the problems, of course, we know that there are problems to it, and in addition to the problems of the health service weakness and the delivery, there is, yes, the main two problems is of access and the affordability. And when, as the two of the speakers said, that the majority of the people, they are living in the rural and the remote areas, while the health services are concentrated, and they are concentrated in the cities, and there is disparity in the distribution. And like I would again quote Zafar Mirza, that the poor are becoming poorer, and they are going below the poverty line because we don't have health services over there where they are needed the most, and where more than 60% population is living. And that is the reason that there is accessibility issue also. So the affordability, in addition to the finances, the additional cost of the transport and the logistics, and they all add up. And then the poorer goes more poorer. So we are here for the solutions, for looking for the solutions. And yes, the solutions and the recommendations given by everyone, they are huge and they are good. And even if we can work on 50% of these recommendations, I feel this is a good solution and a good way up. And yes, there's a dark tunnel and there is darkness. But for me, there is light at the end of the tunnel, firstly, because, as Dr. Safdar said, we are not alone in it. There are so many countries that are facing these challenges. Rather, the majority of the countries, they are facing this. And there was, in COVID-19, there was a report that said that the essential services are disrupted in 92% of the countries. So this added all that. In spite of all this, as Dr. Zafar said, that the index, the UHC index has increased, whether it is increased to 42% or 52%, but it has increased from 37% in spite of the COVID situation and in spite of inflation. This gives a lot of hope to me. And that's, yes, then we have strengths. And we have strengths that the government is focused. And I am very thankful to the government that it is focused and it has brought so many policies like essential health services package and so many other things. So it is focused to provide UHC and it is focused to provide PHC. And although we have improved our index, but the WHO says in their the global monitoring report of 2023 that the overall in the world the progress has decreased so much that it is almost a halt. So, but we are still making a progress. So this is very encouraging for me. And then we say that we have so many strengths, like the first presenter, Madam Sonia Omar, which he said that we have one of the best health services, the health services in the Lady Health Services Program, which is an outreach program which provides home health services at the doorstep. So that is a community program, and we have to invest more in that strength. And then we have another strength of PHC, which is rated as and recognized as the one of the best network, the primary health network in the world. So we have those strengths. And we have the government focus. So we need, yes, we need more finances. So that's an issue. So the recommendations as far as the holistically that I would say is that first we need to improve the financing element. And financing, we have to increase the GDP, as Dr. Razia said, that it is 1% of the 1% of GDP is for the health services. So this is very less, and we have to improve it and increase it. And the government funding is required because this is a government and the public subject, and health is basically is the responsibility of the government. So we need more financing from that side also. But yes, they have overall the country has financial issues. So we need other financial mechanisms also, like the health insurance mechanism and like the insurance policies that are there, and we have to look for other also. But at the same time, the talk by Dr. Safdar was also very impressive with a deep understanding. We have to reduce the costing side also. We don't look at the costing side. There's a huge profit margin in everything, especially in the private sector. So we have to regulate that. And for that, excuse me, but I would, in my opinion, we cannot afford services like infertility, going for infertility treatments and for cosmetics and such like more, but we should more focus on the primary health care, and the primary health care is the biggest part of universal health care. And I'm very thankful to Dr. Raza Zadi, who has actually so comprehensively explained the difference between the two. And the primary health care is the major portion of the universal health coverage. So we have to improve that also, in addition to the first level hospitals and the tertiary hospitals that we have and we need. So we have to do that also. But for all those, for the primary health care, we have to go for the weaknesses and we have to improve that. And especially, I would say that health services are dependent on the health workforce, and we don't have health workforce over there. So we have to increase the health workforce there also. As one of the panelists said, that it is less and it is short all over the country, but nobody wants to go there. So I feel the suggestion that the GPs should be included in primary health care over there is a good suggestion. they should be incentivized and they should be included in this system. And in addition to that, I also say that we need to train and then deploy more health care professionals, especially the nurses and the paramedics and allied health sciences people and the LHWs that we are already doing into that system of PHC. And then we have to incentivize them. If we don't incentivize them, we can't retain them there. The problem that pointed out by Dr. Zafar, that we have to retain them there, and for that we have to provide for all this. So I feel that there is a huge lot of things to be done, and yes, public-private partnership is required. At the moment, we can't go just for the public, because at this stage we cannot afford losing the 70% health services that are provided by out of pocket by the private sector. Mostly by the private sector. So we have to include that also. We have to include them to increase our health service coverage. Then I would say that there has to be intersectorial collaborations and we have to work with them, because there are huge level of regulations that are required. Like one example already given, and I would give another example. If you can prevent road traffic accident by wearing a helmet, why not wear a helmet and save that cost? So we need all those regulations. So there is a cross-sectorial requirement of so much. Similarly, there was a talk about changing the syllabus, which I absolutely agree that in community medicine, we are not focusing on the preventive element. We are more going towards the curative element. And yes, I would also agree that the private sector is more towards the curative and prevention is left for the public sector, basically. So we have to have the change of curriculum, as well as the change in the mindset that everybody's business is this. So for that, we need the education sector collaboration. So there is so much cross-sectorial collaboration that we need. So we have to go for so many things, but I would end up and I would say that we need to utilize all our strength and operationalize PHC and work for UHC. And for this, we need comprehensive and integrated approach to mobilize additional resources, especially finances. So we need the government focus is already there, and we need its collaboration with the national and international organization. We need public-private partnerships. We need cross-sectorial collaborations. We need collaborations with NGOs. We need collaborations with communities. In short, we need everyone to make efforts for the universal health coverage, to take every measure and every step. And yes, every step counts. So thank you very much.
Thank you very much, Dr. Sava. Before I hand over back to Dr. Razia, I would just make one recommendation, and I think that this is such an important subject, and there is such a big crisis, and definitely there is a movement towards betterment. But I think we should not wait for an annual conference to discuss this.
If you allow me,
yeah.
There is one thing that I would say. I want to say it, so I would say it.
Please.
In the army, you said about the army system. So I feel the best recommendation, as keeping in view the army setup, would be accountability. If we have a monitoring and evaluation system, yes, we need the information system, whether it is manual or electronic, but actually we need accountability. If you don't have accountability, you will not get quality out of health services or the products. So you need accountability.
So what I was saying was that we should have more frequent such discourses on such an important subject of health of people of Pakistan. And I think that SDPI should join hands with few other organizations, our university being one, School of Universal Health Coverage, and maybe others. And we should actually regularly convene, monthly or 2 monthly. We should select a subject. And this was a very rich discourse today. And I'm sure that all of us have learned something out of this discussion. And I think we should continue this. This will be my only recommendation. Thank you very much.
So thank you very much, all the panelists and all the participants. And we are almost an hour over our allocated time, but this was such a rich and very focused and comprehensive discussion, and all the panelists were so much prepared and so much like it's a really big contribution towards this conference, and I think the outcome of this will be presented to the government. And very rightly said that it's not in the health. Intervention is not in the health. It's outside the health also. The social determinants of the health has to be taken care of, and the environmental and the climate change is there. And we need to focus on the policies which are really futuristic, as well as we have to factor in that also. Thank you very much all, and please we are going to have a group photo, so please come to the
tea afterwards. Where is the
tea? I don't know. I don't know. So we can have so no, we are interested. Sorry. So please take the panelist